So it's time now for me to welcome you to this wonderful Friars Leaders program. We are pleased to have students, faculty, staff, special guests, and friends, and alumni. And it's always a meaningful moment for us to come together, and especially so tonight as we welcome Dr. Paul Farmer. We are ordering Dr. Farmer a T-shirt that says, what, Katie?
I'm Paul Farmer, and everyone at Simmons loves me.
I'm Paul Farmer, and everyone at Simmons loves me. He needs that kind of an ego boost. We know that. So let me tell you something about the Friars Leaders Program. Many of you have attended other events that are sponsored by the Friars Leader Program, and it's a special program to those of us who know Eileen Friars. She's an alumna from the class of 1972, and she has been incredibly generous to her alma mater, and she is always looking for opportunities to do something meaningful for this community. She has sponsored now a series of important opportunities for us to hear from people that are very special guests here at Simmons. And we are, in that spirit, welcoming Dr. Farmer tonight. Eileen could not be here tonight for reasons that are very special and important. And I want to assure you, if there were any way she could have been here, she would have been here. So in welcoming Dr. Farmer, we're really welcoming one of the people in the world who is an extremely accomplished healthcare professional. Let me tell you, having spent a few moments with him, a few moments of his life with him today, he is a very humble person, and everything I say that is positive about him, he'll be doing this. I know. But I think it's very important that we say the kinds of things we're saying about Dr. Farmer and several of the other people I'm going to talk about tonight. And I'm especially reminded of this after a conversation this afternoon with one of our students who is a student leader. And she said how very important it is for students to genuinely have the opportunity to meet models of what they can aspire to in their futures. And so the Friars Leaders Program allows us to share such models with our students and our faculty and our staff and the whole community. But I want to reiterate how important it is that we have models of leadership in every endeavor in the world. So Dr. Farmer, I'm not just talking about you, I'm talking about everyone who takes a leadership role in important matters in this world. We need more of them, and I know many of them will be Simmons students. So Paul, in thinking about your visit at Simmons, while we know that you're a world traveler and there's practically no place you have not been, we want to be sure that you know that there are other people in our community who, like you, have really shared their expertise broadly. So before I formally introduce you, I wanted to introduce several of the people in this audience who make a difference in the world. First, I'd like to ask Dr. Anne-Marie Barron to please stand. Anne-Marie. For the past 4 years, as the Associate Dean of the School of Nursing and Health Sciences, stand up. You too are a leader, Anne-Marie. Anne-Marie has collaborated with a team from Massachusetts General Hospital to establish a bone marrow transplant unit in Bangladesh, training their nurses in the highly specialized field of oncology nursing. Her work has made a difference by elevating the status of nurses in the region, by providing expert advice to nursing professionals, and by helping to deliver a higher level of care for the local population. Thank you, Anne-Marie. Our health sciences team has also established working partnerships with organizations in Egypt, Israel, and the Dominican Republic, as well as Ireland, all of which are intended to bring our expertise and compassion to health systems and people in those nations. I want to make a personal note that I remember clearly when Anne-Marie came back from one of her trips to Bangladesh, talking about people who were actually receiving chemotherapy in the corridors in the hospital because that's all the space there was for her program. So we are talking about truly pioneering work when we think about the work that Anne-Marie is doing. So thank you for that, Anne-Marie. Among those listening online to this evening's events is Dr. Harriet Fields, an adjunct faculty member in our online master's degree in nursing program. Dr. Fields is a healthcare activist involved in an ongoing grassroots project with a local NGO, non-governmental organization, I hate to use acronyms, in Rwanda. The program empowers women in rural communities with a focus on a train-the-trainer healthcare delivery. Now will Professor of Social Work in the Simmons School of Social Work, Dr. Hugo Kamya, please stand, and Assistant Professor of Social Work, Joanna Almeida, please stand. Dr. Kamya is a native of Uganda who arrived in America some 30 years ago. His research focuses on how the impact of war and political turmoil affects the health and well-being of immigrant and refugee children and families. His travel to South Africa, his native Uganda, and elsewhere has heightened his cultural sensitivities because, in his words, best practices require that practitioners engage in culturally responsive ways. Assistant Professor Dr. Joanna Almeida focuses her research on the healthcare effects of the immigrant experience in this country. Her groundbreaking study in December 2016 was the first quantitative, nationally representative examination designed to identify discrimination as a possible key link between anti-immigrant policies and health. Thank you both for your accomplishments. You have truly improved the lives of the citizens of the world. Dr. Elizabeth Scott, please stand. Where is Liz? And Dr. John Quattrochi, please stand. Dr. Scott is Associate Professor of Biology and co-director of the undergraduate program in Public Health, and Dr. Quattrochi is Assistant Professor of Public Health. Dr. Scott is one of the world's most foremost experts in hygiene. As founder and co-director of the Simmons Center for Hygiene and Health in home and community settings, Dr. Scott has leveraged media coverage to educate people around the world about health issues related to the transmission of microbial pathogens. I think that means you want us to wash our hands, Dr. Scott, in the indoor environment. In doing so, she has helped people neutralize countless hygiene-related health threats. Dr. Quattrochi is a quantitative social scientist who studies such factors as epidemiology, economics, and political science in support of humanitarian aid when it's needed most. He is currently focused on how to build resilience and prevent gender-based violence and female empowerment in the Democratic Republic of Congo. Thank you both very much. I hope this brief snapshot shows just a little bit of the sense of the excellent work being done by Simmons faculty, staff, and students, and showcases how deeply the Simmons community is involved in finding healthy solutions to some of the world's most troubled areas and greatest problems. And now I'm pleased to introduce the moderator of this evening's program, our own Senior Vice President of Academic Affairs and Provost, Dr. Katie Conboy. Please welcome Dr. Conboy. And without further ado, I am pleased to introduce Dr. Paul Farmer. He and his organization, called Partners in Health, are dedicated to transforming global health, to marshaling resources, and to traveling the globe to provide quality help to people around the world who need it most. Without a doubt, Dr. Farmer is one of the world's leading doers. Dr. Farmer not only realizes injustice in the world he does something to fix it. Born here in Massachusetts, Dr. Farmer founded Partners in Health in 1987. It has been said that, quote, he is a man who would cure the world for bringing quality health care to impoverished and underdeveloped nations, including Haiti, Rwanda, Lesotho, Russia, Malawi, Peru, and beyond. For his tremendous intellect, passion, and success, Dr. Farmer has been recognized with the Conrad Hilton Humanitarian Prize, a MacArthur Genius Grant, the Peace Abbey Courage of Conscience Award, the Bronislaw Malinowski Award for a lifetime commitment to the application of the social sciences to contemporary social issues, and has been awarded honorary degrees by Emory, Holy Cross, the University of South Florida, and Northwestern. He is currently the Chief of the Division of Global Health Equity at Brigham and Women's Hospital and Professor and Chair of Global Health and Social Medicine at Harvard Medical School. Dr. Farmer, we are so grateful for your visit this evening.
I think they'd like to get a photo of the three of us before we begin. Yes. What a surprise.
Great appetite for
Thank you. Thank you, Helen. Are we mic'd up?
Yes.
Okay. By the time you have to say anything, you will be too,
I will be
Dr.
mic'd up.
Well, good evening, everyone, and I know that you join me in welcoming Dr. Paul Farmer tonight. We have been so excited about your visit, and I know that we are live streaming this event. It's the first event we've ever live streamed, and as President Drinan was saying, there are so many students who have asked for this kind of thing in the past, so we're delighted that we can have them access this event at the same time. So I guess I might be the very most delighted person of all. I can remember when I first learned about your work, and I mentioned this story in passing earlier, but I was going to New York City back in 2003, and I was going to get on a train. So I was a pretty new provost, and I had been an English professor, and I was packing a bag, and my husband said, "Do you have a book?" And a friend of mine had handed me Tracy Kidder's book, Mountains Beyond Mountains, and said, "You have to read this." And my husband said, "You don't want to take that book."
You want to take Women, Poverty, and AIDS by Paul Farmer.
I think he had a different idea, like Middlemarch or something, you know. But he said, "You don't want to take that book." And I said, "Oh, I do want to take that book." I got on the train, and New York might be my second favorite city in the world. And I went to my hotel room, and I didn't leave. I couldn't put the book down. I couldn't stop reading it. And tonight I had a nice little prompt in my memory from that time as well, because I met a Simmons student in the SOM healthcare MBA program who was, in fact, a student at Stonehill College where I was at that time. Mm. And he reminded me, Wesley Evans, who is here in the crowd tonight, he reminded me that, in fact, I loved the book so much that I insisted that the very first year read that would happen at Stonehill College was Mountains Beyond Mountains, and that was
and
Wesley
not Women,
Evans'
Poverty, and AIDS.
first year. It wasn't. But,
Thanks, Wesley.
So it's great to have you here, and I think I'm going to ask you the first question that I asked myself when I read that book. I said, who is this guy? Who is Paul Farmer? And I guess I'd love to know a little bit about how you became who you are. Were you one of those kids who always knew, I want to be a doctor, I want to save the world in some way or another?
I need a T-shirt for that, too. I am beloved by I'm serious. I got a briefing which may have inadvertently contained your notes. And it said, it's a good thing, because it was full of really nice stuff like, everybody at Simmons loves Paul Farmer. I find that highly improbable. I think I did know that I wanted to be a doctor really young. For example, far earlier than I can recall ever seeing a doctor. And people will ask this question we ask this. I do it all the time when I'm writing about someone. I'm working on, since you missed women, poverty, and AIDS, I'm working on a book about Ebola, but I wanted it to focus on survivors and those who didn't survive. And so I started writing about 2 of our patients who were fortunately did survive. Long chapters. Anyway, all this to say, I don't know if what we do when we're telling a story is say, okay, this happened, then this happened, and they're related. And that's surely true of everyone. But I grew up in a family of 8, and we all had the same experiences. And well, one of my brothers, let's put it this way, was a professional wrestler on television for 10 years. John can vouch for this. And when he goes to Haiti, the Haitians look at him and say, same mother, same father? And so, I mean, I thought I knew that I wanted to be a doctor, but it was a good thing. Even when I applied to medical school, I only applied to Harvard Medical School, not because I thought I would get in, but because I was too disorganized. This is all prior to things called the internet, okay? We actually have to, you remember this time. I'm glad no one asked me, why do you want to be a doctor, even in my interview? Because I'm not sure that we know the answer to those questions. We can grow into them, And so the things that I said as a child or as a college student or even as a medical student, they might not have been true yet, but I wanted them to be true. And, you kind of get to grow into who you are, I think.
How did you know you wanted them to be true? Were there people who had represented something to you? Were there kind of aha moments? Were there mentors?
Absolutely, but you keep marching the clock back, right? When you're, in the examples I'm talking about, these 2 Sierra Leonean, they're both young. One was 27 when he survived Ebola, and the other was maybe 39. My colleague Katie Krylowitz, who's here, knows them both. But I kept on marching it back. You'd find out about their horrible illness experience, and you go back and say, oh my God, they must have survived the war, because they were both, one was a young adult, and the other was a teenager or a little bit younger. And then you keep marching it back. You could always make those claims of causality, A led to B. But I think when I march it back, I can at least identify from in high school mentors. Unfortunately, I didn't say so at the time. I did, by the way, this is to all you undergrads and master's students and PhD students, go back and thank your high school teachers. You'll be glad you did. By the time I was in college, of course, I got to meet people who I still work with and still admire. And I also got interested in health and social justice in college, much more than as a kid and growing up in rural Florida. And I started learning about structural violence and how racism and class and gender inequality, how disparities also work their way into the body. I was really interested in that as an undergraduate, and that's thanks a lot to medical anthropology. I'd never heard of medical anthropology. I took the class because it had the M word in it. Yeah. And I'm still a medical anthropologist. That was in 1980, by the way. How's that feel for you, undergrads? And then you go to, I didn't plan to go to Haiti. I wanted to go to West Africa. Haiti was plan B for me. And I applied for a Fulbright. I was a senior in college at Duke. And I applied for Fulbright. I thought, I'm going to get it. I'm so handsome. And everybody at Simmons loves me. And I didn't even get an interview. There's another thing I tell students all the time. Things don't work out the way that you expect ever, right? They never work out the way you expect. But by then, I was either faking it enough to actually feel it. Yeah. It's like, I can't not do this. And Haiti was plan B. And I'm going back this week, I still go to and work in and live in the same village that I went to in 1983. And so, again, I'm saying this in a way, I'm not trying to be humble, I'm just saying you can, everybody has higher aspirations and more base ones, right? You don't have to be a Catholic to believe that. And you stick with something for a long time, and then you get to teach, right? And I have the best job in the world as a Harvard Medical School professor and a doctor who gets to teach. Even sometimes if I have to teach with difficult people, like John, your new faculty member. He was really trouble. Actually, that's not true. He was awesome. So there are all these chances to keep moving into who you'd like to be, I think. And I hope students here feel that sense of possibility. And someone said to me today, one of the undergrads, so she was introduced by Judy, the dean of the nursing school, as someone who wanted to follow my footsteps. And I was like, you can be sure that you'll have your own footsteps that will be better for you, but inspired by all kinds of people. Anyway, that's how I look at it. Many mentors, many people who inspired me. And living in Village, Haiti as a 23-year-old American, you also come to understand that some of your heroes and mentors are women living in poverty who have a lot of kids and somehow are getting through every day and every week. So I have a lot of mentors who never had a chance to go to college or do some of the things that I got to do. Sorry, that's a very long-winded answer.
No, that's actually quite wonderful, and it gives a bit of a context for other kinds of questions we might ask. So when I think about the fact that you were still a medical student in the early 80s, and yet by 1987 you had founded Partners in Health, I guess I'm curious about what you imagined that might be. When you wanted to just begin Partners in Health, what was the idea? And then how has the model grown and changed over time?
Well, the model has changed less than the reality. In other words, for the first 10 years, our work was very mediocre. But you never tell yourself that, right? You always... First of all, when I got an interview at Harvard Medical School, I thought, as one does, Yahtzee. Because the guy who interviewed me was the chairman of admissions. I still know him. And, I know that I was telling the truth when I was bragging about our work, but it makes me shudder to think back on how mediocre it was for the first 10 years. Now, that's not something you say until you're more mature, I think. So when we were young, we had a vision that is the same vision that we have now. I mean, even if you look back at the first brochure for Partners in Health, it says to make preferential options of poor in healthcare while generating new knowledge and serving people directly. That's a pretty good idea, actually. Yeah. And it doesn't get old, right? So are there poor people in the United States? Of course. Are there poor people in Russia? Of course. Are there poor people in Haiti? Everywhere people are marginalized by, again, I mean, it's not just, it's not just economic poverty. There are other forms of structural violence, and they tend to come together. So it's a good mission statement in the sense that, unfortunately, we're going to have a lot of work to do. Not unfortunately, it's actually very enjoyable work. But the vision wasn't that different. It's the actual implementation and the quality of the work that's getting better. Does that make sense?
So the vision and the mission remains kind of the same, and the location moves?
The location, also quality of service. I mean, let me just skip ahead 30-something years to West Africa, to Sierra Leone and Liberia, where Partners in Health has been since, not since the summer of 2014, when the Ebola epidemic was revealed to be a really serious problem, but September or October, it took us a while to get back there. It's a big ship to move when you're talking about 15,000 people, and always a strained budget. Because if you have a mission statement like that, it doesn't say, make a preferential option to the poor in healthcare if it's cost effective or sustainable or a good idea. It says do it. And so it's hard to get, you can't add on new places in the carefree way of a consultant who's not there responsible to deliver the services. I'm not saying consultants are carefree, but even as a consultant in a teaching hospital like the Brigham, if you're an infectious disease consultant, you're not the primary caregiver, right? There's a team of nurses and physicians who are the primary team. So, we're working with our colleagues to be the primary caregiver. Now, I was telling a story, and I bet you John thinks I lost my train of thought. I haven't. So you're in West Africa, and we're looking at Ebola. Well, Ebola or any serious ailment or injury, in order to respond to it effectively, you actually have to have staff, stuff, space, systems. And it's really clear with Ebola because with the wrong space, you have ongoing transmission. With an absence of staff, maybe you could limit a small outbreak in a rural area, but you couldn't do it in a city. And that staff has to include clinical experts. If we had fewer infectious disease doctors and more nurse practitioners who know how to put in an IV, it would have been better for the outcomes of the patients. And then, you need systems. I mean, this is anything to do with infection control. And there are a couple of germaphobes here, along with Donald Trump. He's a germaphobe. You really have to have systems, or So how long does it take to pull that stuff together? It takes a lot of time, which people don't have in the middle of an emergency, and it takes money. So we don't move lightly. This is a huge leap for Partners in Health. To even after almost 10 years since we started in Rwanda, is a big leap for a lot of people because it implies a long-term commitment, decades in any case. And that was a very long-winded answer again. I'm working on concision, Helen.
I think everybody's wanting your long-winded answers, so please keep it
Well,
up.
everybody loves me at Simmons.
We know that.
By the way, I love how you say, "Oh, thank you for coming." I mean, my office is at One Palace Road in Simmons. My office is here. People, the Simmons students walk by me all the time, don't even look at me, don't even say hi, don't care at all. So trust me, I'm coming in thinking that was hyperbole.
They just don't know who they're seeing. So when you think about the name of your organization, Partners in Health, who are the partners that your organization needs to effect its mission on the ground wherever you are?
Well, the primary partner are the beneficiaries, and using words like local is just shorthand, right? This is global health work, but it's local as well. So the primary partners, if you're in Haiti, it's the Haitians who you serve and the Haitians who you work with. If it's in Rwanda, same thing. In Russia, PIH Russia, all of our staff, our medical staff, are Russians. That's because there are a lot of them there. In Liberia, not so much. So the primary partner is the beneficiary, because I think it's okay to use terms like beneficiary. It's like, wow, can't we even say patient anymore? Patients, afflicted communities, survivors. So the partners have to start there, I think. And then once you have this notion, well, it really is about them and our service to them and our work with them. For example, these people I mentioned that I'm writing, I have already written about both of them. They were our patients, but they've long been our coworkers. We work together. Both of them work for Partners in Health, along with most employed Ebola survivors in Sierra Leone. I bet you they work for Partners in Health. The largest number. I don't know about most, like more than half, but the largest number who are employed surely work with us. And that's been typical. I mean, whether you're a survivor of AIDS, not curable but survivable, or tuberculosis, a lot of our coworkers were our patients at one time and will be their patients at one time or another. So the partners include survivors who aren't the intended beneficiaries now, but who once were. And many of them are alive because they had access to care, probably most of them. The survivors, though, can include academics, right? I mean, I don't work for Partners in Health, and I never have. I've always been a volunteer. I have a job. I'm in the 1%. Thank you, Harvard Medical School. I can afford to. And as a grad student and a medical student, I had a stipend, and it's still compared to the people I was seeing in Haiti, in rural Haiti anyway, in any case, I understood my privilege early on. It can include your university presidents. It can include people from business. Indeed, Partners in Health would not have been funded by people in their 20s, founded by people in their 20s, if one of our founders wasn't Tom White, who was a millionaire, and we were 27, but he was 60, and he invested. We treated him like a peer. He was our partner in Partners in Health and a founder, but we were poor and he wasn't, and that's a handy partner to have, as every provost knows too. So my view, and I could go on and on. I mean, there's no time, as I hope is obvious, where our partners didn't include students, right? Because we were students, and our teachers, they were in, and again, I mentioned, business folk, right? And we have natural allies who regard as partners too, social justice people of all stripe. But it really, hate to say it this way, but it takes, if you really want to have an ambitious mission like that, even if it's only grounded in certain places, as it is, it really has to be a big tent. It has to include a lot of people who aren't ordinarily partners.
Have you reached a point, or was there ever a point when you actually had more volunteers than you knew what to do with?
Well, I think that just because we didn't know what to do with them doesn't mean that we were right. Yeah. Right? So, yeah, but we were wrong, not the volunteers. Mm. And I heard today, or yesterday I got a note from a friend of mine who's a professor at Boston College, who's a well-known Jesuit theologian, who has some presidential scholar, she's an undergrad, who's already applied to all these places. I know when I went to Haiti, I didn't have any assignment, and I kept on looking around. I would go to places, like I went to a famous hospital, a charity hospital, and said, "I'm free, I just want to volunteer." And they said, "No, we don't have any place for you." Too bad for them. No, I'm kidding. That's an undignified commentary. But my point is, I think I would have been good as a volunteer for them. But it's hard to absorb the energy and goodwill. If you, for example, if my Harvard college students, because I teach undergrads too, they go off and do some internship at a consulting firm. That consulting firm is hugely cushioned and financially able to absorb their youth and goodwill. We should be that way, not to take sides, the evil capitalist no, I'm kidding. I think in health and social justice work, we have to try harder to not be that group that says, it's too much hassle. So yes, we have often felt as if we had too many volunteers, but in my view, you could never make the empirical claim that we have enough volunteers, right? It's just a diagnosis of our own, overwhelmedness, if that's a word, or inability to absorb that goodwill, but not a reflection of the need for that kind of goodwill and investment in health and social justice. And health and social justice is a broad term on purpose. Like, you don't want an undergraduate volunteer to be doing your neurosurgical procedures.
No.
Community-based neurosurgery. Classroom down the hall, Simmons. We got a case about to start.
So I want to ask a question about leadership.
Some of my friends from the Brigham are here, my nursing colleagues. I hope they won't tell on me.
I want to ask a question about leadership, which I think is sometimes considered a bit of an empty word. And at Simmons, it's something that we actually take very seriously, beginning with our undergraduates and in all our graduate programs, really helping our students to be thinking about how they can not only move into the worlds they want to move into, but how they can lead from a variety of positions in organizations. I'm interested, you're widely praised as a leader. Do you think of yourself as a leader? Do you think of yourself as having a certain kind of leadership, or would you talk about your leadership?
Well, ever since I knew that everyone at Simmons loved me, I knew I was a great leader. No, I think I get. First of all, I want to compliment Simmons on this commitment at the level of undergraduates, grad students, faculty, everybody. And I think it's palpable. You feel it. And I wish that I had been more intentional about that and as a trainee. It's like when you become a department chair, it's not like you went through a training program to lead or starting an NGO. Usually the problem is that people think too much of their leadership skills, right? And I don't think that's my sin. I don't wake up in the morning and think, gee, how can I be a great leader? I really get to work with a lot of people and divvy up those leadership roles. I don't think any of us shirks them. But if there's a style of leadership, I'm very comfortable leading from behind or with a group, and because I just don't have any experience. I mean, whether you're at the Brigham or in Liberia, for example, there's no way to deliver care without your colleagues, particularly nurses. It's just a fiction, a social fiction I think is probably gone now, but there was this idea when I was a kid. Like I said, I'd never even been to a doctor. My mother argues that point, but I don't recall it.
You don't recall ever having been to a doctor?
Except when I broke my arm and my father said he would like to set my arm for me. I said, Dad, you're a school teacher. Take me to the hospital. That was it. And the emergency room doctor was a little bit tipsy, if I'm not mistaken. But, and my arm is still not able to extend forward. Wait a second, I should sue him. I think all of us can learn leadership. This is back to the Simmons model, and that we ought to start earlier and not have these. And I know the business schools, including this one, teach it better than we do in medicine. And I bet you they teach it better than we do in nursing as well. That there is, there's more to this than I understood as a smart aleck grad student, which John no longer is now that he's a faculty member.
So really, you've seen what works well for you is a more dispersed leadership.
Well, that's why we called it Partisan Health.
Yeah.
Is that we got that. You don't go into a place like a squatter settlement in central Haiti and not understand that you, an individual, will get absolutely nothing done, maybe things that are worse than nothing done, but the real promise is in working with others. And, this is contrary to a lot of things that we promote or promoted earlier about leadership, that it's really about you and your achievements. If you're a pole vaulter, maybe, or a novelist, but definitely not if you're a doctor.
So earlier we were joking a little bit about the fact that I was introduced to your work through Tracy Kidder's book and not
Women, Poverty, and AIDS. So much for your feminism.
So we do all know that you've written extensively about health, human rights, the consequences of social inequality.
Sure, I had to bring you the book.
You gave me the 600-page book.
It's called Punitive Giving.
Which I will enjoy. I'm interested, though, in thinking a little bit with you about...
I wrote in the book, only an English professor or my mom would actually read a book this long.
So you can count on me. I don't know about your mom. So when you think about those intersections...
Still reading Women, Poverty, and AIDS. It's also 600 pages long. Big bestseller, 4 copies. I'll let you get the question out, but I'm just trying to make people relax.
We're having some levity. So I named health, human rights, the consequences of social inequality as among those things that you've written about. And I wonder if you'd talk a little bit about how you see those things intersecting in the work you've done.
Well, first of all, I was very interested to hear about some of the scholarship going on that Helen mentioned here, because this is, that's the empirical work, right, that will reveal, I think, or promises to reveal The language I used earlier, saying how does this get in the body? How does like racism, gender inequality, how do they get in the body? What are the actual mechanisms by which that comes to pass or doesn't? In anthropology, which, I think you mentioned, or Helen did, that I did graduate studies in anthropology. The paradigm that was used a lot was called embodiment. How does it get in the body? Useful term, useful concept in any case. But the way
I have a book with that word in the title.
I saw it, unlike...
Just saying.
Yeah.
Have you read it?
No, okay, busted. I should have kept it going. Katie, I told you I need to memorize the name of that damn edited volume of hers. Health and human rights, the pragmatics of it, in my view, I mean, this is just a view. There are other people who are more sophisticated about this than I am here in this room today, I'm quite sure, is that there are multiple ways of getting to the same destination. And, as students, for those of you who are students, one of the things that you should not be ambivalent about doing is really trying on concepts and language. You don't have to get it right in the first decade. I just said to you, we spent, a decade doing mediocre work. I'm not proud of saying that, but I think, we could have sped that process up by continuing some of these exercises. Now, one that comes to mind, or came to mind some years ago for me, is there are a lot of different ways to get where we're going, which we're saying is, well, health and social justice is decent enough shorthand. Better, more healthy lives, more chance to live up to one's possibilities, et cetera. So what are the main logics that are used, that could be used to support that? Well, some people, it depends on the background of the folks considering, for example, in my experience working with elected officials, not just in Africa, but anywhere, including here, is that if you can make an economic argument, for example, that investing in healthcare is a great way to decrease poverty, and you're going to be judged on that. That happens to be true, right? So health investments to break the cycle of poverty and disease, that's a readily made argument, right? Or at least it is if you learn the basics, and they're not rocket science, right? And another one that's very common in schools of public health, which is somewhat different from the public health programs that are being planned to be launched here in the fall, which are, in my view, more correctly focused on equity. But everyone in public health will tell you that there are public goods for public health, right? Tuberculosis is airborne. You want to privatize your tuberculosis programs in neoliberal fashion, you'll be sorry, because we have data on that. Public goods for public health. You can think about public safety, you can think about whatever you want. So those are two different complementary frameworks, right? One, the development framework. Two, the public health framework. But what is the underlying safety net, the mother of all frameworks, if you care about health and social justice and the rights of the poor? It's probably a health and human rights framework. Because you can be beaten down by argumentation, I'm sure. I mean, after all, why is it that it's only in the last few decades that it was obvious that investing in girls' education, for example, is a poverty reduction strategy, or that investing in basic healthcare delivery services, poverty reduction? This is in the last 20 or 30 years. And, but the health and human rights framework is always going to be with us. Of course, I think it's the same as a social justice framework, not a different one. Now, other people would disagree, looking at the pedigree of rights, and say, well, that too can be a kind of, I don't want to use shorthand or jargon, but a neoliberal trick, for want of a better term. At the same time, when you're talking about the right to health care, which is different from the right to health, the right to health care is something that you can measure more readily. Right? Do people have a right to health care? No. What are the steps by which you increase the enfranchisement of people who don't have that right? Well, you could look at this country, for example, and see steps taken to increase franchise or decrease it.
Yeah.
And so I think when I talk about health and human rights, I'm talking, yes, about social determinants of disease, right? But health care as a human right, is not so difficult to defend because you can say, well, we didn't say that everyone has an equal right to protection, for example, from pollution, although we think that would be good. Saying here, if epidemiologists spend decades arguing about social determinants, as they will, and we will, we're saying healthcare delivery, easy to measure as to who has. Like we can, if you say X million people will lose their insurance or will gain insurance, that's because these things are not easy to measure, but a lot more easy to measure than, the social determinants, which also need measuring. So anyway, that's a long-winded, again, way of saying that I think the health and human rights framework does not displace those other frameworks. And there may be more than the ones I mentioned. I'm sure there are. But it is always useful if you're thinking about poor people and otherwise marginalized people. Again, it's not always just poverty. There are lots of ways to be marginalized. I don't think that we can let go of the health and human rights framework. And we should hang on to it proudly, in addition to whatever other frameworks we may wish.
So as healthcare, as Partners has been bringing healthcare as a human right to different places in the world, what are some of the recent successes that you can tell us about?
Well, back to the leadership question, if I were a good leader, there'd be a lot more of them. So I'm humbled about what a mediocre leader I am, because to me, Partners in Health is a tiny organization. It's much smaller than a number of other humanitarian organizations. But this is a health and social justice organization. It should be bigger. Like we should be a lot bigger. The rate limiting step is resources, right? For example, it's not passion, right? It's not talent. Whether we're talking about Haiti or Boston, it's not passion or talent. You find plenty of people. Is there an established framework to move forward? To actually spend your life doing this work. And when I say spend your life doing this work, it's not like I'm still living in rural Haiti. Right? I'm headed there, but I have a day job, and so this work means many different things, right? You can do lots of different ways to do it. But some of the things that we're proud of, which I will mention, some arcane things. For example, if you have equity, the E word, in your new public health degree that's coming up, which I think is great, by the way, I just want to say, and I was saying to Judy and some of the nursing faculty, we should do the same thing in clinical medicine and nursing, is we should just openly say we're interested in equity. And, we did. So big example and small example. I'll start with a small example. So when you have an equity focus and a rights-based focus, doesn't mean you live up to it, but you have it in your mind at the very least. When there is a new development, a new technological development, let's say, that could be a new medication. It could be a new diagnostic. It could be a new preventive, like a HPV vaccine, right? The question that we're supposed to ask is, what is our plan to develop an equity platform to make sure that our people get this, our people being people who are shut out of the commodification, right? If it's a commodity they have to pay for, they won't get it, right? So hepatitis C. Hepatitis C, I remember because I was in medical school, and it was a big deal when these viruses were being discovered and serologic tests were developed for them, right? But the treatment was terrible and not very effective and toxic, like a lot of treatments, have been and will be less and less, I think. But then came along oral therapy. Now, oral therapy, multi-drug regimens that are curative, that's how the antibiotic era started with tuberculosis medications. Same for ARVs. And we were just talking with the ambassador, because when you were in Kenya and were able to preside over this big shift with the Bush administration's treatment program, there's an equity platform. Some people were not expecting that to come from the Bush administration, but it is the largest equity platform in American foreign policy history, period. So hepatitis C, like, what's our plan? We needed a plan for HIV. It took a while, right? We needed a plan for streptomycin, and other anti-tuberculous agents during World War II. We didn't develop them. That's why we have drug-resistant TB. So what's our plan with hepatitis C? Well, we still don't have an international equity plan, but what Partners in Health did was to say, okay, we will try to get these medications and bring them to Rwanda, right? Or to a Siberian prison, So anyway, to people who would not otherwise get them. And, no one's ever heard of that endeavor. It's being led by one of the Brigham faculty who's been working in Rwanda for a long time, and our Rwandan colleagues. That's an important thing that you've never heard of. I bet you there are a lot of people inside Partners in Health that don't even know much about it. Right? Now, so every time we do that as the collective we, not just Partners in Health, but the collective partnership, that we say, hey, here's a new technological, not fix, but like, how many people, if you work in rural Africa or rural Haiti, how many people do you see who come in who are sick with complications of renal failure? Young people. And as far as I know, they all die because we do not have an equity plan for transplantation or dialysis in poor rural regions without electricity. Myself, I think that we should be doing transplants. But it's like saying, there's one thing I regret, and I'll get to say it publicly, since you mentioned so lovingly and so many times Tracy Kidder's book. He quotes me, and I know it's correct. I'm sure he's very meticulous. But he quotes me as saying, hey, I'm not saying we need bone marrow transplants in rural Haiti. I wish I had not said that, because that was a dumb thing to say. It would have been better to say, we're going to need an equity plan for pathologies for which bone marrow transplant is the answer. Now, the big, and I mentioned this to you earlier, I even tried to hire you as our provost. We did start a university focused on global health equity in Rwanda, and it's a great place because they're amazing partners to work with. And I'm headed back there shortly for the graduation of the first class of master's students. It'll take a while till we have nurses and physicians, but we'll get there. And they will have been trained, each of them, with equity front and center. And then one last thing that I want to mention, because a lot of people from Simmons helped us out, and certainly from Boston, is this university hospital in Haiti is really pretty wonderful. And you say, what? A renal transplant? Oh, we could easily, if we had the staff, space, and systems, we already have the space. We already have the systems. We have some of the staff. You could do a kidney transplant in a place like that. Hey, a Haitian American who graduated from Harvard Medical School, a surgeon, good friend of mine, he separated Siamese twins in Haiti, in that hospital, with a team of 50 people. And they're fine. This was years ago already. They're doing fine. That's a big deal, And and I think, it's a blow for equity. And let me be a little bit controversial, shocker. So, and this is why I was so excited to learn just today about the new MPH program with equity in the title. So, conventional thinking in public health would be to say it is not a priority to worry about Siamese twins or conjoined twins in rural Haiti. So it's a priority if they're your daughters, and it's a priority if they're your siblings, and it's a priority if they're your patients. So how is it that we can get so moved away from those sentiments that are around equity, right? I mean, they're around love, but they're around equity. And again, that just came to mind as I wouldn't even have listed that as one of the big developments, but it is.
Well, we have to embody it. Right?
And by the way, who delivered them by C-section? They were triplets. How about that? I said, I wasn't there that day. And by the way, I didn't want to be there. I didn't want to be anywhere near Haiti. Now, I did want to be there on Election Day and was, having already voted, American Election Day. But hey, let me not go there. I'm on a happy space, triplets. So, there was all kinds of debate because obviously ultrasound, if you have an ultrasound, you know that there's, and the first ultrasound wasn't done up in our place, but it wasn't even recognized that they were triplets. They were, twins, conjoined twins, but no, they were triplets. And so when they were referred to, this is a university hospital in rural Haiti. People said when we built the hospital, you can't build a university hospital here, there's no university. And we said, yet. Oh, there will be, oh yes. So, one of my proteges, who wasn't even an obstetrician when he started working with us, this is a Haitian guy who's a wonderful director of women's health, and an ardent feminist, I might add.
Read your book?
No, he still hasn't, and I will punish him for that. But, somebody had to do somebodies, a lot of people, nurses and obstetricians and pediatricians. They did that without any fanfare. And then, someone had to take care of them, right? They're in a NICU. You have to have a NICU, staff space. And well, we did. We built one. And again, the public health, standard public health. When I was in med school, I heard this all the time, right? Are you going to invest, and I fell for it. What an idiot. Are you going to invest money in NICUs or prenatal care? And we're all like nodding, like prenatal care, family planning. And we didn't stop to ask, wait, how come we have to choose between a NICU and family planning? That's like ridiculous. And that was the public health Luddite logic of the day in the 80s, is that was regarded as somehow progressive and thoughtful to say, are you going to invest in NICUs or are you going to invest in prenatal care? And we were dumb enough to fall for it, thinking that if we were really thoughtful and progressive, we'd be focused on prenatal care. Instead of saying, wait, some babies do need NICUs, and we should not. Nobody was saying, are you going to invest in NICUs or another F-16 bomber? And if you would have said that in medical school or in the School of Public Health, they're like, oh, you're just being a grandstander, right? But that's just as reasonable an alternative as a more, NICU versus prenatal care. And anybody who's my age, and there are a few of you that old here, knows exactly what I'm talking about because they heard the same stuff, in nursing school or medical school or anywhere else. You lifted your eyes up from the patient, and that was supposed to be the great and piercing question of the day. NICUs versus prenatal care. It's absurd, And you learn a lot, and this is, again, directed towards students. You learn a lot just by becoming a little bit more fluent in the arguments and say, wait, hold on a second. Are you sure those are the choices we should be making? Are you sure we should be choosing between separating conjoined twins or promoting, women's health across the country? Why the country of Haiti? Why can't we do both those things?
I think that's the kind of critical thinking we do help students.
Right here.
Right here.
And I think and I just have to say, this may be the first MPH structured with that out front, but you are picking up the best part of public health from the 19th century and the 20th century by doing this. And everybody who studies public health should be studying public health and equity. Everybody who studies nursing, medicine, psychology, social work, because that's what we do, is we think about, at least in a place like Simmons, and I think most academic medical centers, you think about this, we should just name it and move it forward so that the next generation is not ambivalent about talking about health disparities, equity, et cetera. And it's just part of what we learn.
So that program hasn't started yet. It will in the fall, but we have undergraduate public health majors. I'm sure there are a number of them
met
here
a number
tonight,
of them,
and I'm sure
yeah.
you've met some of them. We obviously have folks both in baccalaureate and master's programs in social work, in nursing, in nutrition, in physical therapy, in so many different fields.
And I should have mentioned nutrition and physical therapy and all, because, again, you ask yourselves, you students or faculty members who are in these programs, when are we not thinking about equity? When, I mean, really, is it, if you're talking about nutrition, if you're talking about, I didn't mean to interrupt,
Yes.
but I'm just saying, I do, but I did. I do think that there's something important about, I already said this to the dean, about identifying this as a priority. And to brag a little bit, we did that at the Brigham. We started a program 12 years ago, a residency program in internal medicine, and said, let's call it the Residency in Internal Medicine and Global Health Equity. And people would say, yeah, but what, is that far away? I'm like, no, Boston's on the globe too.
Yeah.
And I thought it would take years to get this approved by the American Board of Internal Medicine. It was months, and this is a formally credentialed, and other universities have followed suit. But public health needs it a lot, and we all need it, is what I'm saying.
Well, we even have an MBA in healthcare.
Yeah.
And I think we want those graduates to be going out and thinking, even if they might be encouraged to think on the side of things that are about, what we're spending and how we think about that, to also be thinking about these equity kinds of issues. And so knowing that there are so many students and faculty members here, and knowing that everything you've just said about the kinds of things that Partners in Health has been able to do that are really inspiring, and the examples from the faculty that Helen mentioned as well that are also inspiring. I wonder if you could give our students some advice, if you will, about what they might be thinking about as they consider going out in a world that needs them, to think about the ways they can contribute to social justice, but particularly in the health-related professions.
Well, I think the advice is going to be general, right? Because you'll have the specificities and I'm always happy to talk to students about specificities, right? I mean, that's what we do in one-on-one sessions and sometimes. But the generalities are important too. First of all, most of you are taking up, are training in and will take up tough jobs, in the sense that, it's never, if you're a social worker or a nurse or, go right through the list of program, physical therapists, no one goes into this because those kind of professions, the helping profession. I don't know why people are snarky when they say helping professions. I think it's a perfectly fine term. And it's not easy. But one thing to keep in mind is if you stick with anything for 30 years, even if the first 10 years are not so hot in terms of output, the second and third decades might be okay. That didn't sound very encouraging. But, it's like stick with something. And in order to stick with something, you really have to love it. So none of the areas of training that are available here at Simmons, none of it means that you're cast in stone like a medieval guild member. That your career trajectory is cast in stone, right? Inside nursing, inside, any of these arenas, social work, there are all kinds of different options. And another thing to keep in mind is your own role in them will change over time, right? It'd be great if you can find something that you'll love doing. Now, I love the work I get to do as much now, more now than ever before, right? And although the nature of it has changed a lot, and that will happen to you students as well. Your roles will change. The other thing is, try and be a teacher, and a student at the same time. You don't have to be. I just ran into a friend of mine from the Brigham, who's on the nursing faculty here, and yeah, we could tell she was an awesome teacher decades ago, right? But maybe she didn't know that she'd be a full-time nursing faculty member. You know, I mean, I didn't think when I was an intern that I would be a professor at Harvard who was still doing the work he loves to do in places like Haiti. You know, if I'm gone a lot, oops, too late, they tenured me. Good system, by the way. Work hard, John. You may. Okay, sorry. You know, the deans, they hate tenure. Provosts, they're in between. So those are a couple things. You know, find something you like, stick with it in one way. It doesn't mean you don't change your role. Be a student and a teacher, meaning a lifelong learner. You know, probably being a student is even more important than being a teacher because that'll come naturally with time. But being a student, we can't forget what it's like to understand that we're ignorant. An example for me is going to West Africa. I definitely thought I knew a little bit about West Africa, having worked on the receiving end of the slave trade, you know, in Haiti, for example. A little bit about West Africa, since that's where everyone in Haiti comes from. And I was wrong. I just didn't know anything. And that's as long as you can say, look, I don't know anything about this place, but I'm going to learn, that makes life enjoyable, right? To be able to be a student forever and ever. World without end. Amen. You know, those may sound like platitudes, but I promise you they're not meant as platitudes. And then finally, the most important thing is you got to find people you like to work with. You know, in any of these professions that were mentioned, again, not one of them is about what you do. It's about what we do. And that's the best part of the work, by the way, is getting to work with pretty awesome people. You know, and whether I'm at the Brigham or in Haiti or in Rwanda, I really admire my coworkers, and I really like being around them. So is that too touchy-feely and vague?
No, I don't think so. I think that, you know, for our undergraduates in particular, I think there's a moment in your life when you have a lot of passion and you're feeling that there are things that you want to be able to do, and you don't feel hooked up with what will help you achieve these goals that you have. It all feels a little out of reach. And so
well, that's why I wanted to tell you those stories about applying for a Fulbright. I didn't used to tell those stories. I mean, like I hid that away like it was a shameful scarlet letter. Applied for Fulbright, was not granted even interview. You know, but again,
is there an A?
Yeah, there's an A. Yeah. It's a big F. Loser. You know, or the idea that, you know, you have to exaggerate the quality of your work when you actually couldn't possibly be doing good work in a place like rural Haiti because you didn't have the staff, space, and system. Yeah, it's normal to do that. But it's, you know, don't think it's straightforward. Just stick with something you really care about and be around people you care about. And that's like the best thing you can do. And yes, you will go back and do other programs and other, you know, and if you're a lifelong student, some of those will be leadership, you know, acknowledging leadership as something you could learn about. And sometimes it'll be continuing ed. Again, this may sound like a bunch of platitudes, but that's been my experience. You know, to illustrate it with one story, because actually this person is related to why I'm here, having traveled all that way from one palace road. This is my landlord right here.
And we're grateful to you.
Well, thank you. See, I got I missed that one.
Yeah, you did.
So my boss at the Brigham 16 years ago, was a guy named Gary Gottlieb, a psychiatrist. And we became good friends. And he joined the board of Partners in Health. Then he moved on to head up Partners, the parent organization, which we point out, hey, Partners in Health was there way before you guys. But unfortunately, it's big partners, little partners. But the punchline for the student is, guess who the head of Partners in Health is? Gary Gottlieb. And if you had said to me, okay, will the head of the largest healthcare provider in New England become the head of a small public charity focused on poor people? And the answer was yes. And I kind of knew it. Of course, I was using his daughter, who was a student of mine, his wife, who's a friend of mine, anything I did to get into him and say, you will lead Partners in Health. I'm kidding. But I'm saying that's kind of cool, right? That your boss, is willing. He already had a destination job. I mean, I wouldn't. It's hard. That would be a hard job, not one that I would care to do. But a lot of people said, he'll never take this job. But he cares about health and social justice. And he could see what we did. And he's head of Partners in Health. Which is kind of a story, I think, about sticking with something.
Yeah.
Because, it's not anything that would have happened until 15 years after we started working together.
And I don't know what the exact connection is to your being here tonight, but I do know that the first time I ever heard Gary Gottlieb speak, he said the words, Helen Drynan is a leader among leaders.
Yeah,
So
he told me that too.
I recognize that there's a connection. Yeah.
He's a pretty special guy, I think. And I'm glad that he's doing this work. It isn't easy, but I know it's meaningful to him because he's a health and social justice person.
Now, I've gotten to ask a lot of questions, and I could ask more, but I know that there may be folks in the audience who would like to ask questions, and even some of our friends who are live streaming this, who may be sending with the hashtag Friars Leaders, FRIARS, LEADERS. So if you're trying to send a question, use that hashtag, and if you have a question and you're in the room, we have folks with microphones who are going to kind of walk up and down and let you ask a few questions. And somebody will have to cut me off at some point because I'd like to stay up here for a long time.
I'm digging it. Hashtag blessed. It worked. That's the first time I ever said it. It worked. The struggle is real. They're not your jokes. They're Beyonce's jokes.
Yes, we have a question back here.
So I'm the Stonehill freshman that Katie alluded to earlier. I'm
Hi,
sorry
Leslie.
that I did not read Women, Poverty, and AIDS, but I still have time.
Yeah, I'm not letting you off the hook, buddy. You're not a freshman anymore.
No. Yeah, so I'm just finishing up the School of Management, and I actually just got back from Nicaragua. I worked with a pediatric health clinic there.
It's
and it was
Nicaragua.
Nicaragua, yeah. And I guess my question to you is, you talked about staff, you talked about space, you talked about systems. When you started to talk about equity, I thought you had meant equity with a capital E from the business sense and standpoint. So you've worked at different places throughout the world with Partners in Health. Can you just speak to what has been the most challenging? Has it been staff getting trained physicians, nurses on board, or has it been just money in donating? If you can speak to the challenges, and if those are universal challenges across the different countries that you work in.
Well, first of all, that's a great question, and I get the equity joke, believe it or not. It's not a joke because it really is the answer to your question, I think. It is primarily about resources. And I hope I threw in stuff, right? Staff, stuff, space, and systems. So we do have things that we need as well. And when I say we, I'm not just talking about medicine. I'm talking about the full panoply of the health-related professions. But let me just say, because one of the questions in the same briefing that said everybody at Simmons loves Paul, one of the questions was very similar to this one, and I thought about it on the way over here. If you compare Partners in Health to, let's say, Doctors Without Borders, which is the largest medical humanitarian organization, our doctors and nurses tend to be from the countries where we're working, right? And you can say, well, what do you do in Liberia? And it's a great question, right? Before Ebola, well, let me just start by saying Harvard Medical School has 11,430 faculty members. One medical school. Think about that. 200 med students. Liberia had 25 at the National Medical School. Before Ebola, 5 died of Ebola. fled. I would flee, right, if I were Liberian. So when we talk about the brain drain, it's, the question is, well, how would you do the work you're doing in Haiti, in Liberia? Well, the work we're doing in Haiti did start in a clinical desert. There were really almost no physicians and no nurses in the rural areas where we worked, and there are lots now. Now, why is that? It's not just about salary, although you have to have, I get paid a lot more than a living wage to be a medical professor at Harvard, right? You have to think about, well, why is it that, in Uganda, in a rural area, a doctor may make such a small amount of money, or nurse? What does that mean? How could they not be involved, be drained away to places where they could actually help their families more? But it's a lot more than salaries for healthcare professionals. It's also working conditions. It's the chance for education, back to those old school pedantic points I made to the students. If I'm saying we should be lifelong learners, they're all saying that as well, and saying, I would love to do, you have a mid-level nurse who's been doing, God's work for 20 years in the middle of a very busy clinic in rural Haiti. I wish we were more organized to think about ways of moving him or her to a program like the continuing ed and leadership programs you have here. But that, again, the chief rate limiting factor is equity in the other sense, money. And, I personally, again, back to this question, I don't think, if I were a really effective leader, then we wouldn't always have to limit the expansion of these good works because of lack of resources. And yet that is the biggest. Because if you look at Liberia, where you're going to have to train a whole new generation of nurses and doctors and other healthcare professionals, you do bring in other people. I have a lot of people from Harvard and the Brigham in Liberia right now. I was just bragging to the dean of the nursing school here. Our first assignment was to reopen the nursing school in southeast Liberia and to help the nurses pass their boards. Who did that? Nurses from the Brigham, right? Who went there and lived there and chipped in. And again, how do we free them up from the Brigham? You have to find the money, right? And so in my experience, that's the frustrating thing. Once you get sort of some notion of a model down where it's not all just seeming like you're drinking from a fire hose, even in the middle of an emergency. I've lived through a few of those, let me tell you. It was really hard after the earthquake in Haiti or during the earthquake in Haiti not to feel just blown over by the fire hose, But, you start to see patterns, right, in emergencies where you think we got to do this, 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 and this. And it's always, in my experience, been fairly pitiful that it's been around just money, not passion, not talent. We can get that. There's plenty in the world. Is that?
Other questions? Okay, we have one right back here.
By the way, we have a former ambassador here, and only in the United States, so we always still call them ambassadors. I've been pointing.
Dr. Farmer.
PEPFAR, one little thing I know I'm going on. If these global health initiatives that the American government has been supporting so generously, if they're scaled back, this is a big problem. So let your elected officials know, or find some way of making our collective voices heard, that this is a foolish move in my view.
So thank you, Dr. Farmer. I so appreciate your words about equity and social justice. Simmons also has an ed school, and I'm a product of the School of Library and Information Science. And I'd love to hear your comments about continuing education for your patients and offering information resources for them as after they're treated and after your care for them. What are some of the ways that you continue to support them in their journey of continuing to be healthy people?
What a great question, and thank you for that. I think again, our work has been more mediocre than we understood, right? And I'll tell you why I think that's so and how we're trying to counter it on this scale. One of the things that you lose sight of when people's, okay, I'm going to use a little jargon that from the social sciences. I know that will not bother you. When people's agency are constrained, when people's agency is constrained by extreme poverty, gender inequality, bad foreign policies, coups, there are very few natural disasters. There are really social disasters, even earthquakes. When all this is happening, and you're thinking, we have to try and remove these barriers to health and well-being. Say they have AIDS, advanced HIV disease, and TB, which is classic in my clinical practice. You're thinking, we got to get this person food, antiretrovirals, TB therapy, follow up at home with a community health worker, blah, blah, blah. And then, my experience, or the patient's a trauma victim, had it been an accident, you're thinking, we got to, relieve the pressure on the brain or do some heroic surgical procedure. Don't worry, it's not me relieving pressure on the brain. I think we've been a little bit careless about the very point that you mentioned, and that is that once people do recover, and because a lot of people we see are young people, right? They're young patients. They're in their 20s, their 30s, they're kids. I think it's possible, and I think we have been careless about not remembering that sense of empowerment, which is another word that's often robbed of its meaning, like leadership, right? But if you really mean it, empowerment can be very powerful, right? What does empowerment mean? It means, having a home or having food or things that maybe you in this room wouldn't think about, like not having to trade sex for rent, right? I could go on and on, right? There are really important material ways to think about empowerment, but one of them is information, as you said. And I think, again, the crush of poverty and adverse circumstances make us forget that, personal empowerment does include a chance to learn. Now, that said, that's the negative report on our work. I think the best thing that we do to focus on the health and well-being of patients through empowerment and education is hiring them. And people say, well, you don't hire your patients at the Brigham. And I said, well, if I were the CEO of the Brigham, we would be. I'm kidding. The CEO is a good friend of mine. And I bet she does hire our former patients. But it's really policy at Partners in Health, right? So, and it's been controversial, interestingly, but never with the beneficiaries of the jobs. Never. They love it. So, we have a whole, like I mentioned Ebola, but I just was giving a second talk in England, no less, with a former patient from Peru who was dying. I mean, he was a little tiny stick figure of a fellow when he was a teenager with dying of drug-resistant TB. You should see him now. He looks kind of like a movie star. And there he was. First, he was in Utah. Like, really, you're here? And then in England, right? And that's because he has taken up the cause of drug-resistant TB. The best example I can think of are the AIDS activists, right? Because they made, in a very difficult time, in the 80s particularly, and 90s, they made education of each other central to their activism, thereby helping us very substantially because, when programs like PEPFAR came along, they should take a bow along with President Bush, the AIDS activists, because they were clamoring for exactly this kind of thing for years. And they were already the beneficiaries of this treatment, right? But they had learned a lot by teaching, by studying, and it's a very wonderful story. and it's not over yet. Of course, we need more of that kind of activism. So bad side, I think, we haven't, because of the gravity of the circumstances, and that's no excuse for our perceived gravity of it. We didn't formalize it a lot, but we do when we hire them. And we got to get better at this. How would you like to be a community health worker for 30 years? I don't think it would be very fun, unless you could change it up.
I just wanted to say that I really appreciated that question too, because it was a reminder that there are so many disciplines that are not necessarily focused on health at Simmons, where social justice is also a huge piece of what we want people to be thinking about, and whether that's on the data science and information side of thinking about what we do with health-related data, or whether that's librarians who are working with social workers in the context of an actual library where they may need to serve the elderly, the homeless, the young. There are a lot of reasons to think about these in really integrated ways. I'm getting a 5-minute sign. I know somebody was...
I'm just getting warmed up here.
I know that someone's monitoring, I think, the online questions. So if there is an online question,
Yes.
could we take that? And then we'll go to you in the front row right afterwards, okay?
Yeah, so this question comes from Twitter. How do you work to get more women involved in healthcare field, maybe specifically in the type of work that you do abroad? I know there's probably some dangers in different countries for women specifically to do that work. Maybe if you could talk about that. And any advice for women to get into leadership roles?
Well, first of all, most of our clinicians are women. So I don't know what the number is, but it's a very substantial majority. And that's true physicians, nurses. Now, in a lot of places where we work, most of the nurses are men, but not in. I doubt that's true of any place that with partners in health employees. That's the health professionals, right? So, in my class at Harvard Medical School, the class of 1988, it was the first class where the majority of medical students were women. But that's been the case in Russia for a long time. And the people who go into public health or tuberculosis, it has long tended to be women, preponderantly women. So, in leadership roles, I think we have to pay more attention to, back to the point just made by our librarian, to continuing education as well. And not just for staff, of course, also for patients, as she was saying. But I think we've been weak on that, and that's an important thing. You could learn that from Simmons, for example. That focusing on leadership and actually helping people move into leadership roles, helping them be better leaders, it ought to be formalized as it is here. And we have the founders of Partners in Health were the directors for 25 years, right? First me, then Jim Kim, then Ophelia Dahl, all involved in 1987 and earlier. Now we've got Gary Gottlieb, as I said, and he actually has some experience in this arena, and I think that's one of the things that he's trying to move forward. There are formal leadership groups at Partners in Health in Boston, Rwanda, Haiti, I'm sure in Russia. By the way, all of the physicians we work with in Russia, all of the Partners in Health physicians, they're all women. I don't think there's, at least in Siberia, they're all women. There's a couple of men in Moscow. Yeah, there's definitely a couple of men. Oops, they're going to be mad at me that I forgot them. But not in Siberia. I was right on that. So, it's not about just the numbers or the fractions, but really, as the questioner said, about, leadership, formalizing that development program. And I've seen it at the Brigham too. There's been, I've seen that it makes a big difference to put in leadership programs for women. And sometimes that's pretty straightforward stuff like, well, how do you make sure that there's parity in promotions, which there isn't yet. We're going to have to keep, it's going to be a fight that we need to speed up in academic medicine, and I'm sure in academic everything. I know you didn't ask the question, but I'm looking at you and liking the way you nod. It's very welcome.
We had another question right here in the front row. Oh, I think you had one, right? Yes.
Hello, Dr. Farmer. I'm a senior public health major here at Simmons. And with our classes this semester, we've talked a lot about the cholera outbreak in Haiti and kind of the distress that happened with that outbreak with the UN peacekeepers. And I was wondering if you could talk about how partners in health were able to go into countries like Russia and Haiti and establish trust with the locals.
That's a great question. And thank you. You know, I'll go to the specifics and then the generalities. The specifics, Russia is a good example, as you said. You can read that, you know, you will read that the Russians kicked all the American NGOs out. Well, that's not true. And so I'm not saying that it's easy in any of the places we work, but if there is a reason that we're well liked in Russia, it's because we're working with our Russian colleagues. And we went in at a difficult time in the 90s into the prison system. Now, it wouldn't be easy to go into the prison system in the United States. They were open enough to welcome us in the middle of their distress, actually, right? Without the staff, space, and systems, the humbled empire didn't have them. And, you know, one thing that I heard a lot back in the 90s, and I thought, this is a dumb way to talk to the Russians. And I think we still do it. It was people from the States and Europe saying, oh, you do everything wrong here. It's like, God, that's like anthropology 101. Shut up. Don't say it. It's like, and they kept on doing it. And I would talk to them without Russians, but like, this is not, you know, how you speak to your peers. I mean, it's their country. We're at. Anyway, it was pretty striking, you know, I thought. Of course, they're fully aware of any kind of condescension. And, you know, and I just don't think it's a good way to proceed in the world, you know, whether you're in Haiti. By the way, this is the biggest trap for, you know, back to the biggest problem is having the resources. But I think the biggest trap for, I'm going to talk about Americans because I am an American, in case you didn't figure that out. The biggest trap is thinking we know more than they do or that we care more. What we really have is more privilege and more wealth. And everybody knows it in the world. So if you can, you know, try and, I'm not by nature a humble person, but you can actually program yourself to be humble culturally. Right, Hugo? Did you like what I said? You got to do that. So Haiti, by the time of the cholera outbreak, we were a well-known quantity. You know, I could say, oh, well, my Creole is flawless, which it is. That's nothing to do with it, right? My Russian's terrible. And we get the same welcome there that we do in Haiti. And I think they recognize fellow travelers who are going to work with them in the trenches. So by the time the nightmare of cholera came around to Haiti, our biggest problem was not the Haitians. It was and not even the UN peacekeepers. You know, like every epidemic comes from somewhere, right? And it was really the public health Luddites once again. And this is why you know, why the Simmons program is so special, because it rejects that kind of idea that, it's not really costing. So one of the classic things, somebody's got to write a thesis about this here at Simmons. So the same logic that would say, well, you know, me stupidly saying, well, it's not like we're saying bone marrow transplants are important. I regret saying that. You know, or that we're going to be separating conjoined twins in rural Haiti. I'm glad I didn't say that, right? Or that we can't, the talking points that all of us received in the late 90s was, well, antiretroviral therapy for AIDS, that's for Americans and Europeans, not for Africans, right? You've read about that probably. So those blunders, which all of us can and will make, you know, you got to watch out for those too, because that's another way of saying you matter less than we do. And people pick up on that very quickly. So after 25 years, oh, by the way, I was telling you a story. The public health Luddites, this is not the majority of public health people. It's a minority, right? Say, well, that's not cost effective and sustainable. One thing you'd think that they would always support is vaccines. Whoever heard that vaccines aren't cost-effective or sustainable? But yes, there's a vaccine for cholera, an oral cholera vaccine. We're saying, hey, this new tool, remember I told you about the HCV, same thing with oral cholera vaccine. It wasn't around 20 years ago, the last time there was a big epidemic in the Americas, right? But now it was around, so we said, listen, this is going to be a horrible epidemic after the earthquake. It would have been horrible before. We need to bring every tool at our disposal to bear on cholera. That includes water and sanitation, education, clean hands, vaccines, and for the critically ill, prompt diagnosis and better care. And the public health Luddites said the vaccine is not cost effective. Like, how do you know? Ask people to make it in China. They make lots of stuff for inexpensive prices. That was supposed to sound like wildly inappropriate, right? So, you know, and I mean, that was our big problem. And, you know, the things that we heard about cholera vaccine were the same ones we heard about AIDS, you know, even though it'd been flipped, right? We didn't have a vaccine, treatment wasn't. But it's the same logic. Now, meanwhile, and I promise that I know I'm going on too long, I had a number of friends in the diplomatic corps. And, you know, this is at a time where the international community, which is not a real thing, but you know, had people inside of it saying, well, I don't know about cholera vaccine. She was late for an appointment with me. Since she was an ambassador, it was perfectly correct. And she said, I'm so sorry I'm late. I'm just coming from my doctor's. I said, oh, really? Is everything okay? She said, yeah, I was just getting a cholera vaccine. The chances of her getting cholera are 0. The Spanish ambassador, her brother was ambassador to Cuba. I mean, this is not a family of poor peasants from rural Catalonia made good, okay? The chance of her getting cholera are 0, and I still am glad she got the cholera vaccine. But the chances of people in a slum or along a, you know, river network who were drinking water that came from that river net, they had excellent chances of getting cholera, and every tool should have been brought to bear. And, you know, the Haitians liked it that we were yelling and screaming that every tool should be brought to bear. And we did do cholera vaccination. We just couldn't get the other better funded groups to join us in that. And that's why there's still a cholera cholera epidemic in Haiti. You know, how can we get that to 0? How can we stop transmission? I still think we need to bring in every tool available. It took 50 years, 100 years for the United States to have water security. You think Haiti's going to pull it together in a decade? And anyway, you asked me about cholera. You started this torrential flow. That was a cholera joke.
Well, I have to say that although I would like to ignore the signals from the back of the room and, you know, let a few more questions be asked, I think it's the incredible engagement that you've shown with the questions that were asked and the kind of passion that you bring,
Thank you, Kate.
obviously, to answering those questions and to the work that you do that has made us really grateful to have you here tonight. And we have a little gift for you.
I love gifts.
Yes, we do. And
I want some swag.
I know people will be happy to see that the swag includes,
nice.
all right, a Simmons bag.
Nice.
And in it, we know that you will wear that Simmons cap, right?
Since I said the struggle is real.
And there are a few other little things in there for you.
I love
but
it.
as you travel the world and perhaps occasionally don your Simmons backpack or your Simmons cap, I know I can speak for everyone here in saying that I hope you know that our thoughts and our good wishes, our minds and our hearts go with you, and for some of us who pray, even our prayers. And we want to thank you so much for being with us to share your wisdom and to share your experiences. It's been a great evening. So join me in thanking Dr. Paul Farmer.
Thank you very much.